way. So Dr. Desai is an endocrinologist and clinical associate professor of endocrinology at Stanford University in Palo Alto, California. She completed her endocrinology fellowship at the Mayo Clinic in Jacksonville, Florida, with an emphasis on the management of patients with thyroid cancer. Dr. Desai's clinical practice, located in Palo Alto, California, focuses on the management of patients with thyroid diseases, including thyroid nodules and thyroid cancers. Her clinical research focuses on thyroid cancer survivorship care. Additionally, she is the endocrinology quality director. Please welcome Dr. Desai.
Thank you, Penny. I'm so excited to be here to share with you guys a topic that's actually a specific interest of mine, because I see majority of thyroid cancer survivors, and I got a lot of questions on how much thyroid hormone replacement does one need, and what are the side effects of that? What are the risks and benefits of that? So I'm going to go over all of that today with everyone in the room, and then I'll be happy to answer questions at the end. Okay, so for today's talk, we're going to cover, in order to effectively understand how much thyroid hormone you need, we need to talk about some of the basics of thyroid hormone. In general, we will briefly discuss the basics of thyroid cancer treatment and how thyroid hormone replacement fits into the bigger picture. We will talk about risk levels. We will talk about response to treatment, because these are the two main categories that help me determine how much thyroid hormone we should give to patients. And then I'm going to talk about TSH goals. So a lot of times your endocrinologist will talk to you about how much we're aiming for. Where do we get this number from? So I'm going to go back to how do we get that number. We'll talk about side effects of thyroid hormone at the end. And then what happens if you're on too much or too little, and how we can help adjust that to make this a better experience. So what does the thyroid gland actually do? Most of you already know this, but I did want to quickly review it just really briefly. So the thyroid gland, it actually produces two different types of thyroid hormone. So this is called T4 and T3. So the difference between T4 and T3 is basically the number of iodines that are attached to the thyroid hormone molecule. So 4 has 4 pieces of iodine, 3 has 3 pieces of iodine attached to it. And the active version of it is actually T3. So what happens is there's a whole bunch of T4 floating around in your body. It gets to where it needs to go, like your heart, your bones, your lungs, your guts. And then it cleaves off it drops off that last piece of iodine, and it becomes activated right where you need it. Okay, so that is something that naturally happens when you have an intact thyroid gland that's working properly. And all of this is controlled by not the thyroid gland itself, but the pituitary gland, which is located at the base of the brain. So that's going to tell us the response of what's happening. If there's too much thyroid hormone, it kind of shuts it down, right? So we don't need, if there's too much floating around, what happens is that it just stops making TSH. And that prevents the thyroid gland from actually producing too much thyroid hormone. If there's not enough, it's the exact opposite. So then it increases it way up high so that it squeezes every last hormone out of that thyroid gland. So it's very, very, very carefully regulated. Your body wants to make sure you have the correct hormone level at the time that you need it. So when it's broken, most people don't feel well when that system is broken. And so when we do a thyroid surgery and we take out your thyroid gland, we have to do that from the outside. And this can be kind of challenging. So not every day will be absolutely perfect, because we're trying to adjust for your daily environmental changes, and it's going to go up and down a little bit. But overall, we want to make sure that, that we're doing a good job overall. So let's talk about thyroid treatment options. What are your options? Now that you know about the thyroid gland, how we regulate the thyroid hormone, I wanted to quickly review thyroid cancer treatments, because it's different amounts of thyroid hormone if you have Hashimoto's, if you have a thyroid nodule, very different treatment if you have Graves' disease or hyperthyroidism. So our primary treatment is actually surgery. That's like 95+% of patients get surgery. Very few patients opt to do just plain active surveillance, which is monitor their cancer with no treatment. So we're going to presume that almost everybody is going to get surgery for their treatment. Radioactive iodine, this traditionally used to be given to everybody over about like 15, 20 years ago. In the last decade or so, we've really backed off on giving radioactive iodine to people. So this is currently just being used for extensive thyroid cancer. And then what we're talking about today, which is thyroid hormone replacement. This is kind of a three-prong approach. So surgery, radioactive iodine if you need it, and thyroid hormone replacement. Okay, so that's what we're going to focus on today. So, how much thyroid hormone do I need? This is actually a very complicated question, but I do get this a lot. So, I wanted to talk about what some terms means, so that when you're talking with your endocrinologist, you kind of know what are they actually talking about, and how can I advocate for myself in a better manner, right? So, TSH suppression, that term basically just means giving extra thyroid hormone to prevent the cancer from coming back. Okay, that is the goal of TSH suppression. You might not have full suppression. The more suppressive that you get, the more side effects that you get, of course, but the less chance of the cancer coming back are. Now, we have to kind of manage this risk of what are the chances of the cancer growing back if we did no suppressive therapy versus if we did full suppressive therapy. So traditionally, we really thought that the full suppressive therapy seemed to prevent the cancer from coming back. But over time, as we've done more research in this, it turns out that you don't need so much thyroid hormone, and the cancer still won't come back. So a lot of low risk patients, even if you don't give this extra thyroid hormone, the cancer is still not going to come back because the chances of it coming back were pretty low to start with. So over the years, we've actually kind of the pendulum swung the other way. So we've kind of walked away from suppressive therapy in general, and now we do this more tailorized approach, which may actually be changing with our next cancer guidelines, but I'll tell you what it is currently. And then the reason is that we found out that people live really long lives with thyroid cancer, and so if we give too much initially, you may not have those side effects. It might be fine initially for the first maybe couple of years, maybe 5 years, 10 years, but when we're looking at like decades of a long life, it generally has a pretty big impact and it's not in a positive way. So we want to make sure that given that long life expectancy, that we don't end up with more problems than we started with, which was just the thyroid cancer, right? We don't want to end up with now osteoporosis, heart problems, other things that I'm going to talk about, which have nothing to do with the actual cancer, but are a risk of too much thyroid hormone. So a normal TSH, again, it's going to be different based on each individual lab, but in general, it runs about 0.5 to 4.5. Again, each lab, whether you go to Quest, LabCorp, or local lab, it might be slightly different. Our lab here at Stanford actually runs down to 0.27 is normal. So it's important to see what the normal is for your lab, but generally when our guidelines are written, they've been written as the 0.5 because that's where around most of the labs are. And your actual thyroid hormone dose is going to depend on two factors. Okay, so these two factors are important to keep in mind. What is your risk of the cancer coming back? The lower your risk of the cancer coming back, the less thyroid hormone we need. And how did you respond to the treatment that we gave you? Did you have a great response, which is called an excellent response to treatment? Is your cancer gone? Or is your cancer still there and we're managing it chronically? So these are two kind of important considerations. They're independent of each other. So I do want to say that they are actually independent of each other. But when we determine the thyroid hormone dose, we use both of those together to determine what your long-term treatment dose is. And this is going to change. So this changes the longer that you get away from cancer, the longer that you're in remission. So the amount changes. The amount changes based on your age. The amount changes if you're menopausal. The amount changes if you're pregnant. The amount changes if you have side effects. So a lot of people ask me, well, I've taken the same medication for like 10 years. Why are we changing the dose? You're not going to be on the same dose forever and ever and ever. We will have to make adjustments. Your body naturally makes a lot of adjustments as you get older, as you go through all these different stages in your life. I have to do that all from the outside. So I need a little bit of help. The lab helps me and the patient helps me. So I think it's a combination of the lab and what symptoms you're having at any particular moment that help me determine what a good dose is for you. So let's talk about risk levels. So risk levels are actually completed following surgery. They are independent of the traditional staging that we use for cancers. So the traditional staging that we use for cancers is 1, 2, 3, and 4, with 4 being the highest risk of the cancer coming back. And basically 4 means that, it's spread everywhere in the body. Um, this is actually separate. So the American Thyroid Association kept this as a separate issue. And this only tells me what is this risk of your cancer coming back. It doesn't actually tell me, the staging tells me what your prognosis is overall. So what are the chances that you're going to be cancer free and here in like 5, 10, 15, 20 years? That's what staging tells me. The risk tells me what are the chances that your cancer is going to come back and we're going to need more treatment. So more surgery, more radioactive iodine, more watching with frequent ultrasound and labs. That's what the risk tells me. So again, it's followed surgery, it's independent of your stage, and it changes over time. So you may be low risk, and there's very like 1 to 3% of people in this certain low risk categories, their cancer does come back. And if your cancer comes back, then you're now high risk. Because once you have one recurrence, you can actually have multiple recurrences. We currently don't know exactly why that is, but it's stuff that we're doing research in. So what do we consider low risk? So low risk patients are basically about 5% or less of cancer coming back. Okay, so that's 95% chance that the cancer is not going to come back. That it generally happens if it's only in the thyroid gland. You can have some small, tiny lymph node involvement, but the majority of it is that if it's in your thyroid gland, you're going to be low risk, especially if it has not spread outside the thyroid gland. Intermediate risk. So this is a category basically that's it's spread to your lymph nodes. There's this, which is about 20 to 30% of people on presentation. So it's not a small number of people. By the time we catch a cancer in a lot of patients, it's actually already spread to the lymph nodes. That's about 1 in 5 to 1 in 4 patients. The cancer is already spread outside of the outside of the thyroid gland. So this does, if it's spread outside the thyroid gland, there's an increased risk of the cancer recurring in the long term. And that can be up to about 20% or so. So 1 in 5 patients that'll come back. And then there's this category, which is a pretty high risk. So this can be anywhere up to usually around 20%, up to almost 40, 50%, depending on what the pathology is, how much it's spread. So this happens when we do surgery and we don't get all the cancer. So that's called incomplete response or removal of the cancer. And you'll see that if you have positive margins on your actual pathology, that means we probably didn't get it all, because the cancer going all the way at the end, the chances of there being some left behind are pretty high. And this generally happens if your cancer has spread outside of the thyroid gland. So outside of the neck area. So if it's spread in the lungs, if it's spread in the bones, it's really hard to treat that. It doesn't mean it's untreatable. It's just quite difficult to treat it. And a lot of times we can keep it from growing, but somewhere down the road it may grow. And that's the risk of the cancer. Like it may grow over time. The second part that we talked about is, what is my response to treatment? This has 4 categories. So the last one had 3, and this one has 4. So the first one is actually excellent response to treatment. So what does that mean if your endocrinologist tells you you've had excellent response to treatment? So this is actually somewhere between 85% of low risk patients, 50% to 60% of intermediate risk patients, and about 15% of high risk patients end up in this category. And basically, it means that after we do the treatment, so for low risk, that's surgery. For intermediate and high risk, that's generally surgery and radioactive iodine, all the cancer is gone. So that means currently there's no cancer. So there's no cancer in your bloodstream when we do your thyroglobulin level, and there's no cancer on the ultrasound. So picture is clean, blood work's clean. Then there's this category of biochemical incomplete response, which basically means that your thyroglobulin level that we're monitoring is high, but we cannot find the cancer anywhere on pictures. So we've done an ultrasound of your neck. Sometimes we'll get a neck CT because the ultrasound misses some little tiny spots. So we might get a neck CT, we might get a chest CT, we might get a whole body scan, and we might get a PET scan. So there's lots of pictures that we consider doing if your thyroglobulin is elevated. And it honestly, it depends on how elevated your thyroglobulin level is. So the more elevated it is, if it's higher than 10, then we do a lot more pictures than if it's like 1 to 2 versus if it's under 1. But that basically means we cannot find where the cancer is right now, but there's some cancer floating around somewhere in your body, but it's not big enough for us to see on the pictures that we currently have in medicine. Of course, pictures get better with time, right? The equipment gets better, the ultrasound machine can see more, the CT scans get better resolution. So we might repeat it from time to time, but currently we can't see it. That's basically what a biochemical incomplete response means. A structural incomplete response is basically we found the cancer. It doesn't matter if your thyroglobulin's elevated or not elevated. Most of the time, like 90% of the time, the thyroglobulin level would be elevated. But there's some patients who their cancer doesn't produce a good amount of thyroglobulin for the amount of cancer there is. So it might not be as sensitive as the tumor marker as it should be ideally. So structural incomplete is independent of the thyroglobulin level. We found some cancer. Usually it's somewhere else in the body, and if it's in the neck area, we've biopsied it and confirmed that it's cancer. So I generally don't identify people as structurally incomplete unless I've confirmed on biopsy that it is cancer that's present there. And then there's this indeterminate response category, which is that there's like your thyroglobulin level is just a little elevated. You might have a lot of antibodies that are going up, or you might have like a small 2 millimeter piece on thyroid ultrasound that we don't quite know what it is, but it's too small to biopsy. That kind of puts us in this indeterminate response. A lot of people in the indeterminate response will declare themselves. If it is cancer, it will grow over months to years. If it's not cancer, when we repeat it, it might disappear. Like you had a cold and then you have these tiny little lymph nodes and we're like, what is this? And then we repeat the ultrasound when you don't have a cold and they're gone. So I generally tell my patients, don't get an ultrasound when you have an active cold because we're going to see some stuff that probably is not cancer, and then it's going to confuse us. So this is kind of the indeterminate response to treatment, okay? And then, so there are 3 different TSH goals that your endocrinologist may recommend. Generally speaking, the TSH goals are 0.5 to 2.0. Again, this might change if your lab is a little bit different. So say your lab goes down to 0.4, we might say it's 0.4 to 2.0. This is no suppression, like very mild to no suppression, right? And then the TSH of 0.1 to 0.5, this is considered moderate suppression, and TSH of 0 or less than 0.1 is considered a high risk or moderate, a high amount of TSH suppression. Sorry. So what are your options for thyroid hormone replacement? The first line of treatment is actually levothyroxine T4. Majority of patients, like 80% of patients, do just fine on this. The good news is that it's 1 tablet once a day. If you miss a dose, you can take 2 the next day. The bad side of this is that, it has to be taken in an empty stomach. You have to wait 1 hour to eat or take other medicines. So there's pluses and minuses. But we can add a second medicine called liothyronine, which is T3. When we've done studies overall, there's some people who benefit from this medicine. We haven't quite been able to identify who these people will be ahead of time. So I generally tell my patients that if you're not feeling well on T4 and we've optimized your TSH and you're still having like the brain fog, you're just not feeling well, we can try this. Some endocrinologists will get a T3 level. I personally don't base it just on the T3 level. If you're not feeling well, we can trial it. If it works for you, then we stay on it. If it doesn't work for you, then we don't use it. The downside is that it is a second medicine. You can take it with the T4, but it's a second copay and it's a second medicine that you have to remember to take. So generally the people that it helps, it's like night and day. If you talk to them, they're like, this is amazing. If it's not going to help you, then we just stop it. And very rarely people will get some sort of side effects on it because it's very potent thyroid hormone. So they might not feel the best when they take it. They might get some heart racing, a lot of anxiety. If that's the case, then we either cut the dose down or we just stop it because it's not 100% necessary. So there are some brand names of thyroid hormone, which you've probably all heard of. Synthroid and Levoxyl are the 2 most common oral brand name PO pills. Then there's Tyrosint, which is actually a gel cap. The important thing to remember about Tyrosint is that you cannot cut these in half. So Synthroid and Levoxyl, a lot of times your endocrinologist to get in between doses, right? So doses can go from like 125, 137, 150. But what if you really need like 140 or 145, right? We don't have a very that precise of a dose. So we might tell you, once a week, take an extra half tablet, once a week, take less half tablet. That only generally works with the generics or the Synthroid and Levoxyl. It does not work with a gel cap because you can't cut the gel cap in half. And then it obviously does not work with a liquid because the current liquid ones are actually little packets that you squeeze into your mouth once a day. So there'd be no way of like squeezing in half a packet. We don't recommend that. Other brands are Unithyroid, and then you can actually, it's not a brand name, but if you get generic and the same generic company is making that brand, the pharmacist will tell you what brand is providing for that generic company if you're interested. There's no way of me knowing that, but because each pharmacy is very different, but the pharmacist will tell you what the specific company that uses that generic brand name is. And we've actually done studies on whether brand name is better. For all comers, not necessarily that brand name is better, but there are some people that generally benefit from brand name. Again, there's no blood test that's going to tell me if you're going to benefit from brand name or not. So cost is a huge difference between brand name and generic. So generally, most people get generic. If you want brand name, I'm more than happy to prescribe the brand name. If you're on generic and it's really not working for you, I've made a lot of medication dose changes, then I'll be like, okay, well, we should try brand name, even though it's going to be a little more expensive. I think you'd really benefit from it. And I have that conversation with the patient. So will you need thyroid hormone after a lobectomy? That's actually a question that I get a lot. So traditionally, we didn't used to do lobectomies for thyroid cancer, but now in the last decade, it's really picked up a lot. Lobectomy data that we have over the last 50, 60 years is more from patients who don't have cancer. But so traditionally, about 20 to 25% require thyroid hormone if you're not getting the lobectomy for cancer. Now, our current guidelines recommend that for papillary thyroid cancer patients with the lobectomy, we have your TSH under 2. So normal, but under 2. So now we've actually had a couple of studies over the years. This is probably one of the largest ones, is in 2018, that looked at patients who have had a lobectomy for low-risk thyroid cancer. And what are the chances that they require thyroid hormone? So we actually found out that it's way higher than the 20-25%. What we found is that it depends on your pre-op TSH. So what is your TSH going into before surgery? So before surgery, about 80% of patients have a TSH on no thyroid hormone. Under 2, about 20% have it over 2. And then what naturally happens is if we take out one side, right, we're taking out the lobectomy, that either the right side or the left side, your TSH will increase. Like in the majority of patients, it's going to increase. So what they did is they monitored the TSH post-surgery and about 70%. So we started out with about 19% with the TSH being over 2, and now we're up to 70%. So most people's TSH will actually go up. The risk factors include that if your TSH is generally above 2 before surgery, almost 100% it's going to stay above 2. It's actually, we use a cutoff of 1.7 to give a little bit buffer zone. So I generally tell patients if they're above 1.7, definitely above 2, that they may require thyroid hormone after surgery. If we're trying to keep their TSH goal under 2. If we're trying to keep their TSH normal, which we may update in the future because we're getting more data on this, then it's considerably less versus requirement for thyroid hormone. And I give patients a choice. I'm like, this is what we have the data on. We don't have the data on if your TSH, what happens if your TSH is between 2 and 4 or 4.5. We're getting more data. We just don't have that data long-term enough to recommend that the TSH stay under 4. We are in the process of hopefully updating our guidelines with the data that we have to redo that recommendation, but currently it's under 2. And the reason is that we don't want that high TSH to stimulate growth of cancer on the other side, or if there was any lymph nodes that for whatever reason were missed at the time of the original surgery, we don't want cancer to grow. That being said, if somebody's TSH is 2.5 and they're like, I don't want to take any thyroid hormone, I'll be like, okay, fine, we'll just watch it. If your TSH crosses 4.5, I highly suggest that you take it, partly because there are other side effects of being long-term chronically hypothyroid, including a worsening of your cholesterol, that I would recommend taking a little bit of thyroid hormone. The other thing that determines whether you're going to need thyroid hormone or not is generally if you have Hashimoto's thyroiditis or positive TPO antibodies, you're significantly higher risk of requiring thyroid hormone long-term. So what are the 3 TSH goals? I wanted to go through them individually and talk about who falls into each of these categories. So if your endocrinologist is recommending that your TSH goal is 0.5 to 2.0, this is basically telling you that we're trying to keep your TSH at the bottom half of the normal range. This is considered mild to almost no suppression. This is for low-risk patients following surgery. So if you've had a lobectomy, ideally, lobectomy should be used in low-risk patients only, and theoretically, so this should be everybody who gets a lobectomy. We should keep their TSH 0.5 to 2.0. Now, there are certain scenarios where if you had a lobectomy and then we found out that you had more cancer than anticipated, but you didn't want to go back and get out the other side, we might change this. But for most patients who've had a lobectomy, they stay in this category. We also include intermediate risk patients who've had excellent response to treatment. Initially, they might start out with more thyroid hormone, and then we get down to this category. Also, high risk patients who had their cancer long, like 5-10 years ago, we might end up getting to this category as well for those patients. This is moderate suppression, so your TSH is slightly below the normal range, but not fully suppressed. We're using this with intermediate risk following surgery, high risk patients with an excellent response for usually the first 4 to 5 years after surgery, anybody with an indeterminate response or a biochemical incomplete response where we haven't found the cancer. We do moderate suppression. And then fully suppressed, which is basically a TSH of 0. It's less than the 0.1, but most people end up with just a TSH of 0. So this is high suppression. This is high risk disease initially following surgery. If you've had a cancer recurrence initially, we do suppress. If you have known cancer that we're monitoring, so you have a structural incomplete response, or if you have some sort of advanced metastatic disease that you're on long-term chemotherapy, or you're getting progressive disease that we're doing active surveillance for, this is things that we would use a suppressed TSH goal. So let's switch over a little bit to talk about side effects and why it's not great if you're on too much thyroid hormone. So thyroid hormone is not one of those things that more is better. There's an optimal range, and then once you get past that optimal range and now you're too much, there's lots of side effects. So I wanted to talk about side effects. The scariest and probably the most thing that we're worried about the most is your heart health. So some of you who've been on too much thyroid hormone probably know that it doesn't feel great. And you might get heart palpitations, so you get fluttering or heart racing. Especially as you get older, you may get a condition called atrial fibrillation, which is basically that your heart rate is skipping beats. And the reason that this is an issue is that if your heart rate is irregular, you can actually are at an increased risk for stroke. So what happens is that if your heart's not beating normally, you can actually form a blood clot and then throw that blood clot. That blood clot can move through your bloodstream and cause a stroke. So this is not great at all. Other effects that you can get is that if you're on too much thyroid hormone, you can get high blood pressure. And when we reduce the dose, your blood pressure comes down a little bit. And all of these heart issues increase with age because generally, as every organ gets older, the reserve capacity is much less, right? So then if I'm over stressing the system and your reserve capacity is less, then you're more likely to get these side effects as you get older. The second issue that we worry about is bone health. So this is a decrease in bone density. Again, the higher the dose of the thyroid hormone that you're on can suck the calciums out of your bones. And basically this makes your bones more fragile. It increases your risk of fractures. And this is especially a concern, again, with older women who are postmenopausal. It could be with younger women who have had, a oophorectomy, so your ovaries are taken out, but basically you're in this menopausal state. And has a very negative impact on your bone health as well. A lot of times we kind of glaze over the bone health, but if you have a fracture, especially if you're older, it can actually cause you to have significant issues, cause you to be bedbound, and decrease your quality of life significantly. So it's an important thing to consider. Lastly, one of the things that I consider also is mental health. So the extra thyroid hormone can cause a lot of problems as far as increasing your anxiety level. You can be on edge a little bit more. You can have poor sleep or insomnia. You can have mood changes. A lot of times, patients' partners, spouses, children will kind of tell me that, hey, I think they're on a little bit too much thyroid hormone because they're getting snappy. They're not that nice to be around. So this is also an important thing to consider. Even if your heart's doing great, even if your bones are doing great, if mentally you're not doing great, we might decrease the dose of the thyroid hormone that you're on. So this is actually just a summary of kind of what we use to determine the dose of the thyroid hormone and what goal that we're going on. So as you can see here, the more side effects that you're having, which is if you're having tachycardia, if you've had osteoporosis, if you're having atrial fibrillation, the less thyroid hormone that we give you in general, even based on your responsive treatment. So if you're having this, ideally, if you're having this indeterminate or biochemical incomplete response, we would like to keep your TSH at 0.1 to 0.5. But if you have atrial fibrillation, if you have bad osteoporosis, your endocrinologist might be like, okay, actually, we're going to make your TSH goal a little bit less if you're having lots of side effects. So again, it's a balance between the risk of the cancer coming back versus causing more problems, more medical problems, and bandaging the other medical problems. So we don't want to cause more medical problems, right? So we need to balance this risk. So what resources are available to you? Of course, all of you know about ThyCa because you're here today. I think it's a great association. Other resources, so the American Thyroid Association provides patient information regarding thyroid cancer treatments, a lot of questions that you might have about thyroid hormone replacement, brand name versus generic. And then there is the National Comprehensive Cancer Network, the NCCN Foundation, that also provides a lot of patient information regarding cancer in general, but specifically for patients here with thyroid cancer. So what are important things to remember from the talk today? I'll quickly go through a couple of them, and then I'll be happy to take questions. I saw that there were some questions in the chat already. So really quickly, thyroid hormone replacement is a key element of thyroid cancer treatment. It's one of the top three. So it's surgery, hormone replacement, and then plus or minus radioactive iodine are the three top things that we use for cancer treatment currently. Your dose of thyroid hormone initially after surgery is going to determine, based on the pathology, if you're low, intermediate, or high risk of cancer recurrence following your surgery. So this is going to be the first dose that you're going to be started on. Generally, there's a weight-based dose that you will be started on after surgery, and then your dose level will be titrated up to kind of get into one of these categories until we figure out what kind of response to treatment that you have. So response to treatment is generally done about 6 to 12 months after your surgery or radioactive iodine after the last treatment. It usually takes 6 to 12 months to fully figure out what is the response to treatment, okay? Long-term wise, your dose of thyroid hormone is dependent on this response to treatment, whether you've had excellent, indeterminate, biochemical incomplete, or structural incomplete. And again, the dose that you're started on after surgery is not going to be the dose that you will be on forever. We will go up on your dose. We will go down on your dose. Some people, that's every couple of years. Some people, that's multiple doses in a year. Everybody is a little bit different on that adjustment because we're trying to do it from the outside. This is something that your body does really well. If you have a thyroid gland, it takes care of this. It changes the dose day to day, stressors, responses. But we're trying to do this from the outside. So it can take a little bit extra time to do that from the outside. More cancer is usually associated with a higher dose of thyroid hormone in general. And then side effects include issues with your cardiovascular health, your bone health, and your mental health. Those are all things that I'm considering when I'm helping determine what your appropriate dose of your thyroid hormone dose is. Okay, so I know that was a lot of information. So thank you for listening to me talk today, and I'll be happy to take questions.
So somebody asked, is there a slow release version of Cytomel possible?
Currently, there is not. We are working on doing some research. That is a high category of research. There are some companies that are working on making it, but it's not currently FDA approved and available for all patients. The one that's currently available is generally a very short acting. It lasts in your body a couple hours, and the recommended treatment is twice a day. Now, some people do fine with once a day, but generally the recommended dose is twice a day treatment for Cytomel.
Hi there. As far as monitoring like heart side effects, if somebody is trying a different dose and kind of monitoring that, do you just recommend kind of symptomatically like how they feel and telling them what to evaluate, or is there any value in those, health pulse oximeter watches, or are those too inaccurate to really sort of assess that sort of thing at home?
You can use it as kind of a guidance. The oxygen, the pulse ox part, not specifically, but like if you're looking at the heart rate, if you've noticed that your heart rate is chronically high, that's something to talk to your endocrinologist or the doctor that's taking care of your thyroid cancer. Is that, hey, I noticed that my heart rate generally runs much higher. It's running around 100. The person might get an EKG if they're very concerned about it, or they might just like what I do is I was like, okay, I'll trial a lower dose. We'll decrease it by half a tablet a week, see if it gets better. They're pretty accurate, but I don't. I mean, it's a conversation to have with the patient and see how engaged they want to be in.
Okay. I want to know how to ask or convince my doctor to give me a combination of T3, T4 treatment, even if my numbers don't show that I need that. I have read that many patients feel better with both. I'm chronically fatigued, and when my TSH is where my doc wants it, I don't sleep as well. What could I do to make it better?
So this is a conversation, yeah, that you have to have with the doctor. You can bring it up. That some patients bring it up to me. What do you think about T3? Do you think it'll help my condition? Do you think it'll help me feel better? Most endocrinologists are open to doing that. If you don't see an endocrinologist, you might want to consider seeing an endocrinologist, because a lot of primary care doctors may or may not feel comfortable. I can't speak for everyone. So if you're not seeing an endocrinologist, or if you're seeing an endocrinologist that's not comfortable with it, you might consider seeing a different endocrinologist as well.
Hello, I have a question. Would you recommend a DEXA scan in a patient 40 plus when they get diagnosed with a thyroid cancer and they start, thyroid hormone, and the other is, do you recommend to start calcium in these patients?
Okay, so a couple of things. Whether I get DEXA scans on everybody is actually going to depend on what your TSH goal is. So if you're a lobectomy patient and I'm not suppressing you, then no, I wouldn't necessarily get a DEXA scan. If you're going to be on long-term suppression, then I would more likely to get a DEXA scan before the recommended postmenopausal ages. Again, it also depends if you're in menopause too. So that kind of changes some factors. I don't routinely screen everybody. The other thing is that calcium. So calcium ideally should be coming from your diet. I'm a firm believer that it should come from your diet. I don't want to put you on excess calcium if you're getting a good amount from your diet. So I will have a conversation with you just to make sure you're getting a good amount of diet. I don't think just taking calcium preventively helps people. Maybe if you are lactose intolerant, or if you're vegan, or if there's some reason you don't have a lot of dairy and you're not compensating otherwise, then yes, I might consider it, but in all comers, no.
All right. For intermediate risk patients, what is the chance of cancer returning? You said for low risk, the chance was only 5%.
So that can range. It depends on what your initial pathology is, how many lymph nodes you have, if you had a variant that's more aggressive. So it can range anywhere from like 5% to like 20, 30%. You'd have to be a little bit more, like your endocrinologist can give you a little bit more detail specifically from your case. But generally it's anywhere from like 5 to 20, 25%.
Hi, I've been hearing a lot about the T3 to T4 ratio, and that that they can be normal on your blood test, but that you can still have like some hypothyroid symptoms, and that some doctors are prescribing T3 in these cases. And so I was wondering if you could tell me about that. I'm wondering
Sure.
when you would
So,
need that, and what the medications are and side effects and
yes.
stuff.
So Cytomel is a T3 medication. It's currently very short acting. So as I mentioned before, there's not a sustained 1-day release one compared to levothyroxine, which is very long acting. It stays in your body for a week, right? So there's a big difference between a few hours to a week. The T3 is much more potent. So personally, I don't necessarily do it just based on the T4 to T3 ratio. Like you said, the ratio can be completely normal and the patient doesn't feel well. So I will do a trial of it regardless of your labs. If your TSH is actually normal at the goal that I wanted to, and you're not feeling well. So like say we're shooting for 0.5 to 2.0 and you're at around 1, and you're like, this isn't working for me, I'm getting all these symptoms, then I will add a dose of T3. Generally, we reduce the dose of levothyroxine a little bit if you're at goal. If you're above your goal, like say you're at like 2.5 and you wanted to try T3, then I might just give you the T3 without reducing the dose. Again, it depends on what that TSH is going in. And then try it. You could see a difference within like 2 to 4 weeks. You're going to notice. I check labs at about the 2-month mark. And then if you're overtreated, you generally feel pretty bad. Like you'll get the heart racing, the jittery feeling. You're going to feel kind of amped up, and not everybody likes that feeling. So if you're getting that sort of side effect, I would just say stop it. And if you feel like it's helped, then you generally stay on it.
Okay, this question, hemithyroidectomy taking 12.5 of levothyroxine, TSH 2.67, TG of 6.7, but having many of the side effects, palpitations, fatigue, anxiety related to the level. Stopping the level for 8 weeks. What if these side effects don't disappear? How long does it take for the side effects from levo to stop if it's due to the levo?
So the levothyroxine, the half-life is over a week generally. And again, it's a little bit longer or shorter depending on how much thyroid hormone you have. But on general, we say it's about a week. So it will take a few half-lives to completely get out of your system. I would say recheck blood work in 8 to 12 weeks. 12 weeks is the maximum and it's out of your system, okay? Generally, I would say you would start feeling better in a couple of weeks. You're not going to feel better the next day, but it'll take a couple of weeks to completely to start feeling those differences. And then if after 12 weeks you're still having those symptoms, your TSH will be checked. It will be higher, like almost guaranteed it's going to be a little bit higher. That's okay if your TSH is under 4.5. If your TSH is normal, I would say, okay, well, we just won't do the thyroid hormone dose if it's making you feel bad, as long as your TSH stays normal. And then if you're still having those symptoms at that point, then I would consider looking at non-thyroid related issues, because we're already stopped the medicine. There's nothing else to do. It's left your system after 12 weeks.
I was wondering, I didn't really get a lot of heads up on these side effects whenever I was going through my treatment just with my care team. So I didn't really know about, I just kind of discovered them myself. And as far as risks and what I should and shouldn't do, haven't had any conversations like that. So I was wondering, in terms of like dental orthodontics and somebody who needs to be TSH suppressed, and if there's any risks with that, if it's recommended or not recommended, or if it's just case dependent.
So there shouldn't be any long-term effects for like dental procedures. If you're getting like a major surgery, some surgeons would like your TSH to be like not fully suppressed. It's a conversation to have with anesthesia and surgery if we have to make an adjustment to your dose before surgery. But most of these side effects are actually related to the dose being a little bit on the stronger side. So I would say maybe some people don't necessarily talk about all these side effects because we don't want to scare patients too. You do, if you have a total thyroidectomy, you need to be on thyroid hormone. And so, you know, we want to make sure that you feel comfortable on thyroid hormone, but at the same time also, you know, contact us when you're having side effects. And a lot of like the dose that we start on generally needs to be adjusted upward for most people. So the starting dose might be a little bit less, and then we adjust upward. But of course, if you're getting side effects, it's important to talk to your endocrinologist about that.
Okay, is it difficult to get the thyroid hormone medication correct when you have your thyroid removed if you are also on antipsychotic medications and a lot of mental medications?
No, I don't think it's any harder than other medicines. I think we just dose based to your symptom management. Yeah, I don't think it's necessarily harder.
Okay.
How long do you keep a patient on a highly suppressive dose? Patients 10 years out, high risk, current TSH is 0.02, and it's
Mm-hmm.
maintained that for 5 years or so.
Mm-hmm. What was the question? Sorry.
Oh, how long would you keep them on a highly
Oh,
suppressive
so
dose?
it depends if you've had an excellent response to treatment. So if you've had an excellent response to treatment, we can actually start backing you off on the suppressive therapy. If there's still something there that your endocrinologist is monitoring, like your thyroglobulins elevated, or there's a small spot somewhere, then they might recommend continuing on this dose. But it's generally less is more is what we've moved towards currently.
What is the highest dose of levothyroxine you would prescribe a patient?
Again, it depends on the patient. The doses that are most common, so there's a 200 microgram dose, and then there's a 300 microgram dose. And unfortunately, there's nothing between 200 and 300. So then generally what I recommend for my patients, if they require more than 200, is taking 2 of the doses. There isn't a max dose that I would say that it depends on the patient, how much the patient is taking their medicine. Are they taking it appropriately? What is their weight? A lot of factors go into this, so I don't have a max dose personally.
I have a question regarding the use of biotin for hair loss. What do you recommend patients, since it can affect the thyroid hormone?
So the way that biotin works is that traditionally it's affected the lab testing. It actually doesn't affect the hormone or the amount that we give you. It's just that it artificially changes the blood test that we're getting. So then you might be getting the correct dose, but then it doesn't look like you're getting the correct dose. So what I tell patients is that it's fine to take for a couple of days. I usually say a week, but in the literature, it's like 3 days. Just stop your biotin, get your blood test, and then restart your biotin after your blood test. The newer assays are addressing this issue a lot more, and you actually need to be on very high doses of biotin for it to impact the blood test. So this is becoming less and less of an issue, but biotin that's in a multivitamin or prenatal vitamin is not enough to do that. You have to be on like specific hair and nail supplements to make a difference. And then I just tell them stop it before the labs. Worst case scenario, you don't remember to stop it before the labs. When you see the doctor, you just remind them, oh, I'm taking biotin, and then we'll ask you to stop it and repeat the labs, and then just restart it after the labs.
Interesting. Okay, what would you suggest for someone who has an elevated T4 as well as an elevated TSH, but currently no sign of cancer?
Well, okay, so the T4 number is actually going to be dependent on what time of day that you get it in relation to what time of day that you take your thyroid hormone dose. And it also depends on your lab. So some labs flag a free T4 level based on, they have differences if you're taking levothyroxine versus not taking levothyroxine. So first of all, you have to make sure that the reference range is correct when have a high free T4 that's flagged. Secondly, if you just took the thyroid medicine, it's going to be artificially higher for a couple hours, and the blood test will just artificially be higher. So generally what I tell patients is that check your free T4 level before you take your thyroid hormone, which most people take it in the morning. So I just say hold the dose until you take your lab. If it's generally speaking, if the TSH is high, then we recommend more thyroid hormone. But I mean, there can be cases of lab interference or many reasons the TSH is high. So first I would repeat it, making sure you didn't take the thyroid hormone and the reference range. And then if it's still high TSH, then it's a conversation to kind of figure out why the TSH is high and if you need more thyroid hormone or if something else needs to be done.
Okay.
Yes, Dr. Desai. 10 years ago, when I was first diagnosed and after complete thyroidectomy, I had started the Cytomel because I just was, the energy level was not there, of course. And so it seemed to help for a while, but then of course the heart palpitations came. So then stopped that. But now 10 years, the fatigue hasn't improved. And my heart palpitations, still my heart rate between 100, 115 on a daily basis almost. So I had my cardiologist, I had all the tests done, everything's great with my heart. So I guess I'm just, what would you recommend to someone like me? I mean, I don't want to, of course, get those long-term, possible, the AFib and that, but also just to exist with the chronic fatigue. And I'm getting heart palpitations already, so I don't know what to do.
Okay, so a couple of things. Chronic fatigue can actually be caused by a lot of things other than thyroid. And sometimes the timing is just really bad in that you notice it after surgery, but there was stuff going on beforehand, or like you had. So many people actually see a chronic fatigue expert to kind of make sure that there's nothing like chronic Lyme disease or like a viral response that's causing the fatigue. So one thing is that consider seeing a specialist that deals in chronic fatigue. The second thing is that I don't know the dose of the Cytomel that you were on initially, but you could theoretically trial a lower dose to see if it helped with their fatigue and didn't cause the increased palpitations. But I'd be a little bit concerned if you're still having palpitations and your dose of the thyroid hormone is optimal. We have to figure out why you were getting that. So I think maybe going back to the cardiologist and seeing why is it baseline so high, and then we can work from there.
Okay, if you are only taking 0.25 micrograms of Synthroid, do you really actually need it?
That is a good question. Some people really just need that tiny amount to keep their TSH normal. Now the question is your TSH 2, or are you trying to keep your TSH normal? If you're trying to keep your TSH under 2, then you could consider stopping it. It's one less medicine to take. We are updating the guidelines. They will change. They have not changed currently, but I think we have the data to suggest that maybe in lower risk patients, you might not necessarily need it. But that is unofficial currently. But you could trial stopping it and seeing. Check your TSH in about 8 to 12 weeks. I would say do the 8 to 12 weeks rather than 6 weeks, because your TSH could continue to change up till 12 weeks. So wait that long term and see where it ends up, and see how you feel.
The next one is, sorry, why shouldn't we get an ultrasound with a cold? And
oh, yeah. So some people, when they get a really bad cold, they get lymph nodes, like you will feel your lymph nodes swelling. We will see those lymph nodes on ultrasound, and we won't quite know. I mean, the radiologist can sometimes tell if they're reactive. So if the radiologist writes reactive lymph nodes, that means maybe you had a cold, maybe you had allergy, maybe you had something else that it's reacting to, right? The issue with that is generally we have to get more ultrasounds as follow-ups than we would necessarily get if you came without cold. So it's not the end of the world if you get an ultrasound with a cold, but it just might be more anxiety provoking, that you might, now we have to monitor a little more frequently when we didn't necessarily need to monitor if you'd come when you don't have a cold.
okay, and this I think is trying to get some clarity. They said, wait, if I'm on a higher dose of thyroid hormone, I will get more cancer?
No. I'm sorry if something I said suggested that, but no.
Yeah, I saw that on this is Christina, the moderator on the in-person side. I saw that on the slide too, and it I think it was just worded kind of confusing, because I was a little confused at first too, but then I realized that what you were saying is that people with more extensive thyroid cancer tend to be
Get
associated
more,
with higher
yes.
doses of thyroid hormone, not that the thyroid hormone tends to cause more cancer.
No, I'm sorry. So let me clarify that. So the more cancer that you have, the more thyroid hormone that your endocrinologist is going to recommend. I shortened that. Sorry, I will fix that on my slide. It's not that the thyroid hormone causes the cancer. So again, your dose depends on how much cancer that you had. So the more cancer that you have, the higher the dose of thyroid hormone that somebody's going to give you. So thank you for clarifying that, and I will adjust that for future talks.
You had mentioned the ATA recommendation for a patient with a lobectomy has TSH maintained less than 2.
Mm-hmm.
Does that apply to non-differentiated cancers as well, or is it
so
just
non-differentiated cancers, so medullary and anaplastic, the TSH goal is just normal. Sorry, so those TSH goals are specifically for well-differentiated thyroid cancer, and I will put that in a separate slide in the future too. So that's papillary and follicular. If you have medullary, your TSH goal is normal. If you have anaplastic, your TSH goal is normal.
Can I add something? I'm sorry. I work with Dr. Cabanillas, Maria Cabanillas, and so we do like significant amounts of anaplastic thyroid cancer. I just don't want the patients to be confused. If your anaplastic thyroid cancer, if we know that it originates from papillary or follicular, we may keep your TSH suppressed as well. Just
Yes.
FYI. Yeah.
Yes, sorry. Yeah.
Okay. This next is I was diagnosed in 2003 with papillary. I was stage 3 through the capsule. Kept on suppression for many years. My TSH still runs low, was recently 0.22. I developed AFib a year ago and have had 2 ablations. What suggestions for my current level, and is it likely the AFib is related to the low TSH?
Yeah, so this is the big question is that, did the thyroid hormone directly cause the AFib? It's really hard to say if you were just predisposed to getting AFib and then this like turned you over one side versus another. I would say that if you have AFib, generally I tend to keep my patients with AFib, their TSH goal the low end of normal, so the 0.5. It depends on your lab. And then the other thing is it depends on your response to treatment. So if you have no cancer, then generally we would try to push, like lower your dose to make sure that you don't predispose further episodes of AFib in the future.
Thank you.
I was diagnosed with anaplastic 13 years ago. I was put on Synthroid and Cytomel, and I didn't feel great. And so I read about desiccated, and I got put on the desiccated thyroid, and Cytomel was added, but I still don't feel great. I'm tired, I'm gaining weight, I'm moody, I'm just not good, memory problems, the whole, all the symptoms of low thyroid. Anyways, I'm wondering, should I try getting more desiccated, more Cytomel, or something else get tested? I know you.
At this, like if you are on Cytomel plus desiccated, you're on a pretty decent dose of the T3 already. I wouldn't necessarily think that you would need more. I would consider maybe this is not entirely thyroid related at that point, because the symptoms that are from the thyroid can be caused by a lot of different things, and we don't want to miss something else because we're really focused on the thyroid. So I think what I tell my patients is that if we do tons and tons of adjustments and I still cannot make you feel better, maybe we should just investigate other things and then come back to the table once we've had a lot of other things investigated, rather than just constantly be making dose changes forever, which we could do that too, and trialing different things. But if it's not related to the thyroid, then nothing that I do adjusting up or down, right, is going to make you feel better if we don't get to the bottom of why you're not feeling better.
Because like I am suppressed and it's less than 0.01. And so I wondered if I took less.
If you took less, I mean, yeah, you could trial it and take a little bit less. If you're suppressed and you're not feeling great, yeah, I generally try, I will tell people we'll decrease the dose. As you get older, it actually has the opposite effect. So once you reach your like late 50s to early 60s, it'll actually tire you out more. It's a paradoxical effect where the extra thyroid hormone actually tires you out more. A lot of people think that more thyroid hormone will give you more energy, but that's not necessarily always the case.
Okay, thanks.
Okay, this one is I take T3. I have heard from other thyroid cancer patients that you should not take it, like an urban myth that it is not good for you if you have had thyroid cancer.
Yeah, that's you could take T3 with thyroid cancer. It's fine. It should not be your only medication. You should be on a combination of T4 and T3, but you can take T3 with thyroid cancer.
Thank you.
Another question regarding a patient with thyroid cancer that has been diagnosed with severe osteoporosis and is recommended an anabolic agent such as Stimulus or Forteo. Is there any problems with the thyroid cancer, or the osteoporosis treatments can be used?
All osteoporosis treatments are fine with thyroid cancer. It's not going to increase your risk of thyroid cancer.
What do you recommend for people that have other conditions like ADHD that have similar symptoms to hypothyroidism, where it would be a little more difficult to determine whether the symptoms are because of the thyroid meds or the ADHD meds no longer working?
Yeah, so I would say that's when I use my labs a lot more, is that if you're way outside the lab reference range, then I would say, like, if your TSH is 0 and you feel like your ADHD medicine isn't cutting it anymore, then I would actually reduce the dose, see if your symptoms got better, and then if your TSH went back into the normal range and you were still having the symptoms, then maybe we need to adjust the dose of your ADHD medicine. So I think if you have other comorbid conditions, it can be quite challenging to tell. So that's when I rely a little bit more on my labs to decide whether we need to adjust the other conditions, medications, or your thyroid medicine.
Can you tell me if a dosing approach of starting at a minimum dosage of something like levothyroxine and then titrating up is a valid approach or not recommended? And the reason I ask is the person who was doing this is nervous about starting off at, some like a weight-based significant amount of levothyroxine and wants to start out low and titrate up. Is that a valid approach?
Yes. So what I do is that I use a weight-based dose up until like 150, max 175, but generally it's a weight-based dose up to 150. What I've found is that if you rely purely on a weight-based dose, especially in patients or people who necessarily their weight is really, really high, it does not correlate 100%. So we don't want to be starting somebody on like 300 micrograms because their weight-based dose is 300 micrograms, right? So I will generally start with 150 or 175 and then titrate up from there. Again, it also depends on if the person has heart problems that I'm worried about, I might use a little bit lower dose, or if they're elderly, I might use a little bit lower dose and titrate up. But everybody's a little bit different on what they're comfortable with and their own experience. I think it's generally worse in symptom stuff if you overtreat initially than undertreat. And my patients might tell me otherwise, but as far as is if you overtreat, I've definitely had patients that don't want to be on thyroid hormone, which is not realistic. If you've had a total thyroidectomy, you need to be on some thyroid hormone, as opposed to if we just go up on the dose, people are like, okay, I'm more comfortable that this isn't enough, so I'll go up on the dose.
Suppression dose from 1993 to 2015, thyroidectomy age 5, lung mets, RAI in 2001. Do I need to get regular screenings for long-term side effects as I age? If so, what kind? P.S. Liothyronine synthroid combo. Love the T3.
Okay, so as far as your screening stuff, generally we recommend screening for all other cancers at the recommended screening guidelines. You don't necessarily need to screen for other cancers. Your radioactive iodine dose, if you haven't necessarily gone over the 600 to 1,000 total, you don't necessarily need other screening for that. Your primary care anyway is getting like a CBC, a complete blood count. And if you find things on there, then you might need further workup, but there's not necessarily like other screenings I would recommend at this age for you. Just follow your regular cancer screening guidelines because you're not specifically at increased risk for other like things like breast cancer or colon cancer, unless it runs in your family. And then different guidelines are recommended. But having thyroid cancer does not necessarily mean that you have to be screened for those other cancers differently.
The next one, how long does it take for a body to feel a dosage adjustment of T4, the synthroid?
Generally, a couple weeks. Everybody's a little bit different, but a couple of weeks you'll start noticing a difference if you're going up or down. The full effect can take up to 12 weeks to feel a difference.
Okay, thank you. Have you seen any correlation of T4 and lower heart rate? My dosage was recently lowered and I noticed my heart rate has dropped.
Yes. So the higher the dose of the T4, the higher, especially if you're over your natural body amount, the higher the chances of your heart rate increasing. So the converse is true as well, that if we lower the dose, it might go down.
Okay. The next, I have heard some people say they take their entire week's dose of levothyroxine 1 day a week or split their weekly dose in 2 days. What is your opinion on this? And is there any data to support this practice?
Yes, you can do that. Do we recommend that? No, he will probably feel unwell for like 1 or 2 days until it like pans out. But yes, there is data on that. And yes, you can theoretically do that, but it's not recommended.
Okay. Why does TSH change when nothing else changes? Same dose of tirosint, same time of day, not eating, drinking anything but water for an hour after taking pill, no change in weight. I have it change from 4.5 in June and 0.62 in September.
Yeah, so there are seasonal changes. There's been some data that shows that there's seasonal changes. Your TSH will change with the seasons. Generally, it goes a little bit higher in the winter, a little bit lower in the summer. Secondly, as you get older, we know your dose will change as time goes on. So sometimes it's just aging that causes it. We do look, of course, for other more obvious reasons like the weight change, the added medication, something else changed. You're not taking the same medicine, a different brand. If we go through all of those and we can't, sometimes we don't find a reason why it's changed. And then I will just say, okay, we'll make an adjustment. We'll check it again in a couple months, and then we will figure out, what you need long term. But that's why we check it at least once a year, sometimes more frequently.
Okay.